Hi, Maria.
Hiya.
Hello.
Hi.
Hello. Thank you so much. I'll just introduce. Thank you so much to everybody who's joined our A to Z Medical Series live. Unfortunately, Unsuman is not able to join us today, so it'll just be me and Maria talking about this diploma of geriatric medicine. Because you sat the diploma and recently passed it, so I think a lot of people who are thinking about doing it will want some tips and advice about the resources you used, what the exam actually entails. And I know we've had a brief conversation beforehand, but let's start afresh about everything. So firstly, introduce yourself to the audience.
Hi, I'm Maria Ballas. I'm a GP 3 in Shropshire. I'm working at the moment in GP rotation in women priest medical practice. And I have worked before in Shrewsbury Hospital as a medical registrar after finishing my CMT. Basically, this is how all the interest in geriatrics started, because I've completed the MRCP membership, and initially I wanted to become a geriatrician, but then I thought probably the easier way out will be GP with special interest in geriatrics, so I can
Yeah,
do career and be a mum.
yeah, absolutely. Yeah. And how many children do you have?
I have 2 children,
Yeah.
5 and
Wow. So you're quite busy as well, with everything going on and still doing this
6.
exam. Yeah.
Doesn't let me get bored or
You
anything
never
like
get
that.
bored. Yeah. So you said that you did MRCP, did worked as a doctor in the hospital in geriatric medicine, got the interest from there. When did you find out about the actual diploma during your GP training, that this was something that you could do to show your interest?
Yeah, so initially I've spoken to one of the consultants, one of the geriatric consultants about how to move forward basically. And this was mentioned there. And then
Mm.
after I've joined the GP training, I've actually got a grant from CCG, from local CCG,
Oh wow,
to
okay.
do a bit of work in frailty and geriatrics basically. So a diploma will basically fit quite well with that and
Yeah,
will probably help me do more than I would have otherwise been able to.
yeah,
And I was thinking about it from the beginning, and in terms of preparation, because I've been in maternity during the training, I left it after maternity just because I knew I needed a few months to go through all the resources that are on the website, although I have had the experience working in geriatrics.
yeah.
Um, it is quite a tough exam to prepare because the
Mm.
written exam is only passed about 69% first time or
Say that again.
67%,
So the,
something
the
like that.
exam is, so the written exam is, you have the pass mark, you mean?
There are two parts of the exam, the written exam and the practical part. The written
Right.
exam is quite tough. Only
Yeah.
about 69% of people pass the first and second time. And there is only one opportunity a year to actually
Right.
sit the exam. So I've basically looked at the Geriatric Diploma website from the RCGP, and all the resources are there. And I've just
Yeah.
planned of how to go through because
Think we're losing a bit of connection. So for those of you who might not have heard that she mentioned she went on the website, the RCGP website. That's where she got all the information from for the diploma. I've had a look at it actually. It's got all the syllabus is all on there, and it tells you exactly, the different topics you need to be aware of for the exam. But I think let's hope her connection does rejoin. Oh, she's gone. It's fine. We'll get her back. Um, so it's quite interesting, isn't it? That our population is getting older. We're dealing with more geriatric medicine in general practice, and I think it would be quite a nice refresher to be able to do the exam. and I'm thinking about doing it, but hopefully get more information from Maria as to whether my preparation is enough, and how long she revised for. She mentioned a few months, so we'll see. Let's see if she rejoins. Does anyone have questions that I can ask her when she comes back online? Oh, let's have a look. Does anyone have any more questions, specific ones about the exam? Dr. Salim, maybe you have questions? So let's see, when she joins now, she'll join the live, then I can actually, will I be able to invite her? Oh yeah, I have invited her, so hopefully she'll come back. Hi, I don't know what happened with the connection, maybe it went... So you mentioned that you were talking about the RCGP website, and yeah, we'll ask about the resources and books that were helpful as well.
All the books required for this exam, for the written exam, which is the toughest part of the exam,
Yeah.
are on the RCGP website.
Okay.
I've got it open here because I've got them, but basically...
I was going to say, I actually bought this geriatric medicine handbook, but this is the one that they mention as well in hand, like hard copy, isn't it? That one, the Oxford case history. Does that come as audio?
Yeah, it is. So I've used Z Library.
Oh, right, Z Library.
Online e-books, and they're all free, basically. So I've used that to download PDF books, and I've listened on my mobile phone, basically using a PDF reader. Some of the books are not for listening, for example, in the car, just because there are lots of tables that are very difficult to follow through if you're driving or anything like that. But for example, one of the books, Geriatric Medicine at Glance, it's very visual. So there's lots of diagrams and tables, and there is pictures, lots of pictures. So for people who are very visual and think in pictures, like I am, for example, it's quite. Like
is this the geriatric, the ABC of geriatric? Is that the one, or? Sorry, I didn't hear that. One. Which one again?
The second one. So not the ABC series. The second one. At Glance.
Oh, Geriatric at a Glance. Okay, and the website was the Z Library you mentioned that you downloaded some free books on there. Okay, and there's this book as well that I found. Is that any good? Have you seen that one before? The Geriatric Medicine Specialty.
You're showing it upside down.
Sorry, no, it's because the camera is facing me as a selfie, so it's coming backwards. Yeah, so it's the 300 specialty, a specialty certificate exam question. Yeah, it's good. That's quite a nice read, actually.
Yeah, I haven't used that one. I've used the Oxford Geriatrics. I've used the Geriatrics at Glance, and I've used the ABC series. And also the if for people who don't have much experience on the acute care of geriatric side, the cases are very useful just because it goes through, for example, management of hyponatremia, which is very useful to go through.
Yeah. You mean this Oxford cases? This one?
That one.
This one is a good one. Okay, fine. That's good to know. And
for example, listen to the book. ABC series is very good.
Yeah.
So I've had in total about 5 months to go through the books, but I've listened to the books mainly for the first 2 months, and then I've got the books from library, and I've listened and looked in the book. I've read the book and taken notes. The written exam is all about trying to put it in practice. Is very similar to the AKT in the sense that there will be lots of information. Some of it is not necessary for the case. It's just to sort of find out, and you have to focus to what's important. So you have to see through all that to see the forest through the wood, basically, to be able to answer the question. Um,
Yeah.
it's not
Yeah.
just about regurgitating knowledge; it's about putting it into practice.
So it's like an the applied knowledge test for GP trainees, basically, and try not to go because the stems of the questions are quite long, isn't it? And then you've got to try and tease out.
There is Yeah, sorry. That's why I mentioned it, because there is a past medicine question bank made by physicians, by medical registrars.
So which question bank is
It's
that?
probably
Past medicine.
past medicine. Past medicine is free. I think it's still free. It was free
Okay.
when I prepared. But it's probably useful just to see how the questions might be formulated, not necessarily to prepare for the exam as
Mm.
such. I found it very useful to
Mm.
read all the books. So all
Yeah.
the 1, 2, 3, 4 sets of books listed in there, just because you see the same problem from different angles. And for
Mm.
example, the Oxford medicine, the Oxford Geriatric is very practical, and it has, for example, lots of visual equipment and explanations for the equipment, and this will come up
Yeah.
in the practical part. So
Mm.
to me, it took five months to prepare, just because
Five
I
months.
did with work. I didn't have dedicated time for learning initially, and I've used the last 2 weeks to actually read and listen to the books and make notes. But I already knew what's written in the book, so it was quite easy to do that because I've listened to the book for a few times, to all the books.
Yeah. And how much was the exam? It's obviously two separate fees for the written and the practical. What was the fees for that?
The
How?
fees, I think, is around 250, the written one, and 300 and something the practical. So we around 600 in total.
Yeah.
Um, when I sat the exam, I had to go to Liverpool at fine, but I think at the moment it's online. This is what they've written on
Mm.
the website. It's basically online, so there is a very clear instructions about how that will go
Yeah.
ahead. If you want to go ahead, if anybody wants to go ahead this year, once you make the application for the exam, you can email them. They're very useful, and you can call them as well. I called them a few times, and they were quite good because there was a
Yeah.
problem with COVID, and they they haven't gone ahead with the planned date for the written exam, and there was a bit of misunderstanding when it's going to be and all that. So they were quite
Mm.
good at responding to emails and also calls if it's
Yeah.
urgent or anything like that.
Because
Um,
on the
so
website, you're right. They're doing online now for the written, but I think the clinical exam is maybe still going to be face to face.
the
Yeah.
clinical exam is face to face. It has
Mm.
5 sessions, 5 stations. First one is the history taking, which is very standardized clerking, going through presenting complaint, history of presenting
Yeah.
complaint, um, social medication, and then make a plan with the patient.
Yeah.
And that's all it is. There is nothing fancy about that, basically. In this part, I've tried to do a bit of motivational interviewing to try to let the patient talk and trying to find out how it was in COVID, being isolated and living on his own, drinking and that sort of thing.
Yeah. Yeah.
And it was very useful because I just went over time. Um, so just stick to the standard classes, basically.
Yeah.
And there will be questions at the end, basically. And
How long is
then
each
there is
station? Sorry, I
each
interrupted.
station takes 10 minutes,
10
but for the
minutes.
practical, you have 6 minutes to examine the patient, and then you have 4 minutes to discuss. So in total, it's 10 minutes.
Right. Okay.
If they do make any changes, there will be very clear information about the practical exam, and there is also a marking sheet, a draft marking sheet, so you know what they're looking for.
Mm.
Now, going into stations, the next station, so to speak, is the comprehensive geriatric assessment,
Comprehensive
where they
geriatric
look
assessment.
Yeah, so there is lots of information about it on the British Geriatric Society website. But basically, they just want you to demonstrate that you're looking at the medical, psychological, social, and all the aspects important to the patient's life.
Yeah.
But don't forget things like anxiety, depression. There will be some scoring thrown at you, like what's GET8 meaning for this patient? What would you do with that? So
Yeah.
if you've
Yeah.
never heard of it or never used it, it's very difficult to make it up.
Yeah.
So yeah, in my experience, it's not necessarily the most useful thing to do the scoring with the elderly patients because they might not understand or during the standard practice from those scoring is not going to be necessarily useful making an
Yeah.
anxiety or depression diagnosis, but you need to be aware and to mention that you're scoring, for example,
So
depression
if
in
there
someone.
isn't, for example, if there isn't a mental health issue going on, you still have to show that you would screen the patient for
Yeah.
that. Yeah.
Part of the comprehensive geriatric assessment, you have to look at all those things, the medical, reviewing the medication, looking psychological, social. Is there any equipment needed? What kind of equipment will be? So they will ask you specifically for your patient, how would you improve the access to the bathroom? So you might just want to find that out from people you work with, or Oxford Handbook of Geriatrics is quite good on that, because it shows you the equipment and what they use for usually.
I have
But
to
I'm
say
sure the
that
team
this, how
will
do you
help with
fit
that.
that? In 10
Sorry?
minutes, how do you do a geriatric? Because when you do it in like sort of non-exam mode, it probably takes about half an hour
Yeah.
to sort of go through everything. So how does that fit into 10 minutes?
The way I did it is putting in practice in with the patients I've seen. So I've all the patients I've seen, all the home visits, I've tried to do that. I've tried to do exactly the comprehensive geriatric assessment, review medication, look at
Yeah.
nutrition, looking at social. It obviously takes much longer when you go in a home visit, for example. But it just gets you into the habit, and you kind of have a feel what's important. You have to mention about anxiety, depression, but you don't have to do it. So yeah, when you go in a home visit, they actually do it. It takes much longer. You just mention that look into that,
Absolutely,
or
yeah.
but it might be useful if you use your patients to actually see what actually works in practice, what kind of equipment they need or they've used,
Yeah.
and you can learn from them. You just ask them, so how would you adapt your life or your house to the new situation or medical, whatever it is, basically. But it's important to go through all these aspects to touch on medical, psychological, psychosocial, basically, and in terms of what practical thing you will do to you change medication. For example, before you're going to look into cardiovascular, there is some medication like the classic one is atenolol. You're going to reduce the atenolol because of postural hypertension, but also you're going to look into are they seeing, are they able to see, to hear, to do they need to adjustment in their house? But they don't want to hear just about words. They want to hear specifics.
Yeah,
Basically.
I think I guess there's so much to think about, especially with the comprehensive, the geriatric assessment, because you're thinking about everything, including medication, including practical stuff, including social, financial probably as well. What is their care system at the moment? I know that maybe in that 10 minutes, it probably won't give you so much of a complicated case. Probably think of one issue that you might be, or is it few issues in that case?
I think they're looking in the exam to for you to be able to coordinate an MDT where all this will be discussed, and to be aware what to expect from different teams. They're not teams that are working with you. They're not going to want you to do a full physiotherapy or expression therapy report on a patient or anything like that. But they just want to know that you are aware of those things, and you will be able to basically coordinate the chair of this MDT in the future, for example.
So that's station two. Station one is, station one is history taking. Station two is the assessment. And then,
And then the next one will be ethical, where I had a son who wanted to take his mother into a care home because she's been falling. She was treated for UTI, something like that, in the hospital, and the mother, and she had delirium as well with it. And then the patient wanted to go home with package of care, not in a care home. So I had a
yeah,
discussion of why going into the care home actually won't make us safe from falling point of view, and supporting in the community with a package of care is possible, and it's good enough for her, and it's in the first place less restrictive in terms of respecting her autonomy and her wish basically, and the fact that we checked if she's got capacity, basically still
yeah,
have a position able to recall everything. So she's able to make that decision, and we ought to respect us as a professional and
absolutely.
the front staff. So we just, rather than trying to preach him and be patronizing or anything like that, I've just told them that, I understand that you know your mother very well, but this is her choice basically, and we try to mitigate the risk. And that's why we've introduced all the a package of care, and she's been checked by the occupational therapist, physiotherapist, and basically she will be safe enough to go home. In terms of the risk of falling, going into care home is not going to make it
Yeah.
less basically, because they still fall even in the care homes. So that's not
And that's
necessarily.
quite interesting, isn't it? And in that case, was it just the son that you saw and not the patient, and you just having a third party consultation basically?
I
And
had
so
a
how much
discussion with the
information did
son.
they give you? Did they give you all the information that you needed to be able to discuss all that with him?
No, no. So they just told me that she's been admitted in hospital and she had this UTI treated, and she was a bit confused with it, and she got a history of dementia, and the son was taken back home. But she's been seen by all the therapists, deemed medically fit for discharge, and the choice is to
Right.
go home with the package. So I just went through what the son knows and what the situation's been, and he told me that I was very upset, and why don't we listen to him because he was best. But I try to diffuse that by just saying, I know you know your mother very well and you mean well,
Yeah.
but we actually have personal assessment, and doctors, physiotherapists, and the rest of the people who are quite well involved looking into mitigating their risk. And the plan that we made is actually in the best interest.
Yeah.
And he was, I was surprised that he wasn't fighting that. So
Because you
that
probably
one
did the
was,
right approach, basically.
yeah. So I finished that one in time before the knock on the door.
Yeah.
Basically, there wasn't any problem with that. So that was a full part, a clear path.
A clear path. I think that is,
Yeah.
it just reminds me of when you go into general practice training, or even in it for CSA, if you got a case like that, it is very much about communication, diffusing the situation, letting that person vent, and then slowly sort of, accepting that, yes, I understand you feel this way. This is what we have. This is the situation that's here at the moment, and just trying to calm them down.
It's important to show that you've thought
Listen.
about she has
Yeah.
capacity. This is in best interest. This is the less restrictive method of discharge, and actually, sending it into the care home is not safer. So using those, even if it's obvious to you, trying to demonstrate to the examiner what your thought process is, and it's quite
Yeah.
useful for the relative or whoever you talk to. If they understand how you think and how you made that decision, it's much easier to understand. But also you demonstrate, because you're not going to have time after to discuss a lot of how you made that decision. There will be just a few questions at the end, and at the end they just ask me if I think she's depressed. So I just said I'm sure the medical team has screened her for depression and anxiety, and if she's been medically fit, then I will, we
Yeah.
should have a medical days before
Sometimes I
we
find
can.
that relatives feel they know what is best for that patient, but then actually it's important to involve especially if they have capacity, like you said, because what his worries are, maybe they're not what her worries are, and maybe there's other ways around it than the nursing home. Like you said, interestingly,
Yeah.
that
But it's
you can fall more in a nursing
true.
home.
True, but it's important for them to understand that it's not their decision to make since she has
Yeah.
capacity. So her decision, and we can only support her, even if it's a silly decision, or it's not. If we disagree with her decision, it's still her decision, and we just try to support her and make her less restrictive discharge.
Absolutely. Wow. And then what was the fourth? Was it an examination station next?
So then the next one was my neurology. It's a neurology station. I had a stroke. It was straightforward stroke, but the patient was a lady with a left ankle pain. So I've learned it from PACES, although they say when you go for the exam, this is not PACES, so don't just do what you do in the normal practice. They don't tell you for the practical exam how to prepare, because they just want you to do what you normally do, basically. So even though they said it's not PACES, I've asked, like in PACES, do you have any pain? And she told me about the ankle pain. So I was very, very cautious not to cause any kind of pain at all. Even if I checked the tone and the reflexes and everything, I was very, very careful with that left ankle. Just because I know from PACES that if you do harm patients, that's a clear fail, basically. And I think that's the only way you can actually fail the exam. If you're rude to the patient, or if you're hurting the patient, or if you don't show empathy or compassion and that sort of thing. So whatever else you do, you're going to pass. If you look at the statistics from the website, as I said, 69 are passing the written exam. But if you pass the written exam, you're clear passing the practical exam, except if you hurt or are rude. That's the important thing I want to say. So here I just try to show off that I can do a neurological exam like in PACES. And I went this time. So on the way out, the examiner said, "Oh, just tell me how you're going to investigate this." And I just said, "Oh, CT head, and I'm just going to check for AF on the pulse." And that was it. I couldn't say anything more because I was on my way out. So with that one, I was passed because I went over time basically. But they don't look for anything fancy. Basically, they just want to see that you can do a neurological examination in 6 minutes. It's quite a short time, and if you don't know what you're looking for, I kind of seen that it's a stroke, and I had the inspiration to ask the patient to walk, if she can walk, and she could walk for me, and she had a classical, sort of walking with a right leg, I think it was, the right side. So it was a classical stroke, basically. I had no doubts about the diagnosis. But if you're not sure, I think you just need to practice a bit, and as I said, just practice with the patient to be slick in the examination, because I think they like that confidence that you can make an examination and a diagnosis, and you're not saying something silly.
I was actually thinking about this, about the fact that obviously a new stroke, and if you haven't done acute medicine in a while, generally we don't tend to see just a new diagnosis of a stroke, unless you get someone coming into surgery and they're suffering from that straight, and that's quite rare. Usually people call 999 straight away, and they get taken to hospital. So how do you think examining patients who've already had a stroke?
Yeah, absolutely. If you're not sure, I think it's very safe to have a differential diagnosis. So my differentials are whatever you find. So if you find a breast reflux or weakness or whatever you find, you say, well, I found this, a weakness, a breast reflux or loss of reflux or calculation or whatever you find. Describe what you find, and then my differentials will be a stroke and a mass inflammation or infection or anything like that. If you look at the patient, I mean, it can be, I don't know what to think, what to say. It can be anything acute, basically.
So they don't give you anything acute, Like they give you something that's been there for a while.
I
No.
don't have anything life-threatening or acute as such. You're not going to have an acute stroke. This lady had a residual right-sided weakness after her stroke, a previous stroke, but it's not going to be acute, and she was able to walk. So she, yeah, it's not going to be anything acute. So you just try to think what could it come in terms of chronic condition. If you might
Okay.
have a MS, for example, I have a Parkinson patient.
Okay.
Parkinson is quite classical, I think, in the exam. Probably they will, if it is a Parkinson, clear-cut Parkinson, you can start the examination with a gait. So you can ask, before you do anything, you can ask the patient, are you in any pain? Yes, I have an ankle pain or whatever. Can you walk for me? And if you can actually gain quite a bit from just asking them to walk, like I did.
Yeah.
So I knew from the start this is a stroke because I asked the patient to walk.
Because you go into the room and they're already there, is that right? Then you know.
They're already there. They will be on the bed waiting for you to give instructions, and they will do what you say. But you can ask, are you able to walk? Do you mind walking for me? And from gait, actually, there are 2 or 3 books. One will be the glance, and the other one will be the cases, I think.
Yeah.
In each book, there will be something about the gait. And Oxford Medicine, Oxford Handbook has assessment of the gait. You will gain a lot of information from asking them to walk. So if you get a neurology, be clever, ask the patient to walk. If they say that they're in pain, try not to hurt them. Even if you don't elicit any signs, it's much better than to hurt the patient. That's what I think. Basically, if you don't know the diagnosis, don't panic, because I knew it's a stroke, but what if it was a tumor which caused stroke? So you will never know specifics, and even if you know, that's not important. If you look at the marking sheet, they don't give a lot of markings just for the diagnosis. It's the whole thing, basically, how you the bad manners, how you examine the patient, how careful you are, and things like that. So just make a differential diagnosis, and for all the neurology, differential scanning, and might be some autoimmune screening, or whatever you want to say, but
or CT scan and stuff. Yeah. That's interesting.
And
then what was
that will ask them to walk.
Ask them to walk and don't hurt them. Ask them to walk and don't hurt them. So what was the 5th station then?
The last one is either cardiology or dermatology. So I had a very clear scleroderma, not scleroderma, sorry. What did I say yesterday?
Psoriasis.
Yeah. Sorry. I had a clear psoriasis, so I just told the diagnosis in the first line. Basically, I tried to describe it. The Oxford Handbook Geriatric is very useful, and for that. And then I just, said I'm going to ask for triggers, and if there is a medication that might have causes, if they've tried anything, and activating the creams, and just the NICE guidelines recommendations with stronger steroids, because it's on expensive. And I just showed off a bit. Yeah, because I knew.
Because I guess it's a spot diagnosis, psoriasis, and then you just kind of work back on the patient and then the creams and stuff. Kurum,
I just want to say that's why I come out in the last few weeks to make notes and very specific things. So exactly what I'm going to say about psoriasis, exactly what I'm going to say about, anything dermatology, for example, because I'm very weak in dermatology. So I knew exactly what I had to say. I had a story for psoriasis that I had.
And that's really useful, isn't it? I guess it's useful in general practice as well, because if someone comes in with a particular problem, if you've got a list of questions or issues around that condition that you're thinking of, then it makes it a lot easier to, make sure you're not missing anything. I know Kuruma said here, is it enough to sit this exam just on MRCP and PACES knowledge, or should you read books, resources that you highlighted? I mean, obviously I've not done the MRCP PACES part. But I mean, if I did use this book, with this book here, and I used the Oxford Handbook and the At a Glance, that
So I
should
think the
be enough.
Oxford is most useful for the
The most
practical
useful, the
exam.
Oxford Handbook. This one, Oxford
Oxford is
Handbook.
most useful for the practical exam.
Yeah,
It's not to this exam because it's very specific. So, for example, on the
yeah,
practical exam, they don't just want you to say vaguely what you do in general. It's about that specific case. So on their website, they're listing all the resources. For example, at the end, there is start and stop criteria, basically, which I have used when I've worked in geriatrics. And it's quite useful.
What's
It's
useful?
not
Say,
just
I didn't
about
hear what you said. What was useful?
start, start and stop criteria. So there
Oh,
is
right, for
at the
medication.
end, yeah, for medication. I have used that quite a bit when I was working in geriatrics, but it's useful in general to know what medications are important and what medications are not, and to tailor that to your patient. And they will give you a
Yeah.
specific case. Basically, it's not enough to. You will be very very good in the examination, the neurological, cardiovascular, dermatology. You'll be very good if you've done PACES, but as I said, they told us at the beginning of the exam, this is not PACES. You just do what you do in your normal practice, and they're not testing you as PACES. No.
Yeah.
It's
But I guess
useful
it
if you
kind of
have it
is
because
like
that's
paces.
confident.
Yeah.
Yeah, if you've
It
done PACES,
isn't.
you have that confidence to do it, but it's
Yeah.
not necessarily um, a clear path.
Yeah. Wow. I mean, did you get anything? Did you feel that you got anything that was quite difficult or that you weren't expecting? Or was it kind of all stuff that you were expecting? Like you,
I found it difficult to justify some of the things. For example, on the practical equipment,
mm,
um, I found it very difficult because um, I said that I pull a rail and try to have a staff or to improve the entries in the bathroom and things like that. But because my patient was discharged in a wheelchair. Um,
right. I see.
but I found it a bit difficult to imagine,
Mm,
basically. It's so much easier when you have the patient in front of you. And for example, when I've done the whole visit and I've tried to find how we can help this patient, it's so much easier because you can see how it looks and how, yes, I found it very difficult to imagine because I was a bit nervous during the exam.
yeah.
Um, So yeah, but it was still okay. I still
Mm,
said I said things that they marked me for and passed me, but yeah, I just found it difficult to imagine how that
yeah.
situation be
Yeah.
basically.
I mean, it's obviously our population is getting older. I mean, you're now hoping to set up with this grant a frailty service, and having this diploma will obviously give you show that you've got that knowledge. You've got to base your to sort of use the funding and base this frailty service around that. What I mean, have you got anything in place at the moment? Like, do you do any sort of frailty assessments at the moment?
I've done during my A&E rotation, I've done performer to use all the information that the ambulance is verbally giving to the nurses in a standardized comprehensive geriatric assessment performer, because actually the ambulance are very knowledgeable and they go in people's houses so they can
Yeah,
see that clogged up house full of boxes and things collected over 90 years, or the carpet, multicolored carpet, and no
yeah,
access to bathrooms. They can actually see and what the problem is, social, psychosocial, most of the time. So I've tried to use that to do that performer based on the comprehensive geriatric assessment. Everybody found it useful, but it never was never put into practice because
yeah,
COVID came, and it just needs documentation a bit more than they would have otherwise done in A&E. And the A&E doctors in Telford don't find that useful because there is no frailty system to basically follow up that information. So why would they collect all this information if nobody wants it, if there is no
Yeah.
frailty unit in there? But I think in the long run, it will still be useful to collect information from the ambulance team without necessarily making them responsible for the information they pass on, just what they see, basically. They don't have to make a judgment or diagnosis or anything like that. And to use it, speed up the assessment process for patients. So I hope after my RCA in March, I will be able to do something more about that.
Can I just ask, so say in your practice you'll be doing a frailty service, could other GP surgeries refer patients to you from their surgery if they're, like, what kind of conditions would you be expecting to see in that sort of clinic, or are you just focusing on patients in your practice?
Well, at the moment, because I've got the grant, I have to show that I've done something for the patients in my practice and in my CPN, in my set of practices, basically.
Yeah.
If that's going to be funded after, or if anything will come through, then I can't see a problem to have like a hub where people can come in. But basically, to do a comprehensive geriatric assessment, you can't do it on your own. You have to have a multidisciplinary team, and the doctor will be the one coordinating it. There are at the moment a lot of assessments done in care homes and everything, but they're not actually comprehensive geriatric assessments. And the physiotherapist, for example, our physiotherapist in our network is just a triage first gate physiotherapist. It doesn't actually see people much. It just advises on signposts. Whereas geriatric patients, you're probably in a bit of somebody who has hands-on experience, a bit more expertise into how to deal with specific problems.
Yeah, like I know we've recently had a social prescriber join our practice, so that's something new, and they do mental health. They try and find out if the patient's depressed, or try and refer them to other services they might find useful, like even people meeting up or socializing a little bit. So are you hoping that in the future that you'll be able to have a hub or something where people can refer? Is that something that you're aspiring?
It doesn't matter necessarily, because I have kept contact with a lady who was very interested in this in the CCG. She doesn't work at the moment in the CCG, but she's a working GP. So hopefully we'll be able to convince future CCGs that there is a role to play in geriatric and frailty in this respect. But I don't think it matters as much the frame or the way it's structured, because in the end, frailty and geriatrics is going to become everybody's problem, not just people with special interests.
But in this clinic,
whether I like it or not, you'll have to know
exactly
how to deal with it.
How would, like, a typical patient, I see a lot of frail patients, but who would need your frailty service? So what is it that I can't do in a normal day-to-day sort of practice that a frailty service could do?
Do everything, but to look into their nutrition, to review the medication, to assess if they're anxious and depressed, and if they need anything. What would you do for that? Because most people don't necessarily want to speak to psychologists. They might not have a very good technology knowledge or ability to do video consultations or anything like that. So it takes a lot of time to do all those things. And in some practices, it's left to the AMPs to deal with old people, just because nobody wants to talk to them, and they can't hear, you can't hear them. It's a bit daunting to actually assess and look after them. But the experience I had in geriatrics in Shrewsbury, it's a group of very knowledgeable and friendly people in geriatrics, and basically there is a lot of reward you can gain from looking after old people, because
Yeah.
you're not going to necessarily make it all better. You're not going to make all the 8 comorbidities
Yeah.
better, or the little bit that you add to the care, or the small change that you make, it can be very important to them.
Yeah.
And then they're very, and in terms of physical examination, if you examine them, you're going to find something wrong with them. You know, you just have to examine them, basically. So it can be rewarding. I mean, it
Yeah. It
takes a bit
sounds.
of patience and know-how, but I think in the long run, it's going to be everybody's problem. At the moment,
Yeah.
in the nursing home, there is this assessment criteria. Basically, it's a tick box exercise, and that's very,
Yeah.
very useful in my point of view. But in the future, will probably be more integrated. So, for example, we have to do math scores before we give them supplements. We can't
Yeah.
prescribe them otherwise. And, you know, all sorts of things. In this respect, for people who are interested, there is a lot of information on geriatric medicine journals, and you can sign in freely.
All right.
GM
Geriatric Medicine
journals.
Journal.
And there's
Someone,
lots and lots of
Richard just asked a
webinars.
question. I'm so sorry. Are you using the diploma more just at your surgery or other local surgeries too, in terms of geriatric services? I think you mentioned that you just using it at your practice for now for your funding, isn't it? Is that right?
Yeah, so part of my project is to have the diploma, and then to implement a clinic or a local service that might
Yeah.
be funded in the future, might not.
Yeah.
We'll just have to see. So at the moment, I'm using it for this person, but actually, it was my interest. So I've done it for my soul, I think.
Yeah.
Just because I've worked in pediatrics, I just wanted to have this acknowledgement and confirmation.
Yeah.
But also, it is quite useful in practice. So everything you learn in all those books, you will be able to put it in practice, and it will be to the benefit of your patients.
Absolutely. Yeah.
I can see somebody asked about the Rockwood score. Yes,
Local.
the Rockwood score is
Oh
quite
yeah.
useful, and that's the framework I've used for the assessment in A&E, and it's actually now incorporated in A&E assessment. But it's a tick box exercise, because the nurses are looking at the patient and say, "Oh, this is quite frail. This can walk the toilet, so it's not that frail." Or, you know, so it's not. If the nurses in A&E are using, for example, the ambulance report, it becomes quite specific and quite useful, because it's accurate.
Yeah. I have to
So you
say, like,
can,
I don't really use scores very much in practice. I don't know whether we have a template on EMIS or not. I think I might go back and have a look to see whether I know that the healthcares that go and they visit the patients at their home or on telephone, they do lots of scoring, and I think they do the comprehensive geriatric as part of the QOF and QIF quality framework type thing. But I've never used it myself. Is that something I should be
it's quite
doing?
useful to give you an idea of
Yeah,
how you explain, for example, some of the problems. Somebody who's very frail and he has an acute problem, it will become quite unwell, and it will never go back to what it was 6 months ago. So if you talk to a angry relative who doesn't understand why the PCI made the mum go into nursing home when she was perfectly fine before, she was walking and doing everything, and
yeah,
this made it so unwell. Being frail, basically, that's exactly what it means. So you don't have the reserve, and if they smoke hard enough, frail people are becoming unwell, and they will. It's very likely not to go back to their baseline, sort of thing. So that's why it's important to do the comprehensive geriatric assessment to minimize their frail or to sort of reverse as much as we can. And it might be just a matter that they need their teeth done, or they need their hearing or their vision improved. It might be just a simple thing like that. When I worked in geriatrics, I always had hearing aid batteries, and I still have them in my bag. Just because when you talk to a patient who can't hear you, you can't do cognitive assessment. Basically, you don't know if the patient is really demented or if they simply can't hear. And there were many cases when just by changing the batteries, the AMT improved or fixed it, or whatever you want to use as a score for the cognition. So
where do you get these batteries from?
I bought them.
All right.
I bought the batteries. I bought them online.
Oh, is there anything? I mean, does anyone else have any more questions? I feel we have covered quite a lot. You know, we've gone through the format of the exam, we've gone through how much it costs. So there's a written part, there's a clinical part, which is 5 stations. We went through each station, which is very useful. Thank you so much for sharing that. And some of the difficult cases, some points about not hurting the patient at all, and also thinking about the bigger picture and not letting the noise fog your kind of knowledge, and maybe think about depression and anxiety as well as all the other stuff. Is there anything else?
I think somebody asked about. I think somebody asked about. I haven't looked down the bottom
of what score to use.
And it depends what we're talking about, what we're scoring. So, for example, in the comprehensive geriatric assessment station in the exam, my patient was anxious. So they've asked me, if the GAD is 8, what would you do? So you need to know what the GAD 7 would be basically, and what does it mean if it's a bit abnormal. There isn't sort of good or bad answer, because it depends why the patient is anxious. She might be anxious just because the relative died, like it wasn't the case. So he was all alone, probably going to die alone, and nobody will find him and things like that. So it depends why they're anxious. Are they anxious because they have a health anxiety? They might have a problem in the blood. They might have a hypothyroidism. They might have some salt deficiency. There might be something else that is aggravating their mental health status. And they might be frail. They might. There's so many. A cat might die, and it's simple things like that. Basically.
Yeah.
So
I mean, Richard is saying exactly what I'm thinking right now, because I think the exam's in March, isn't it? And I was thinking, I think, you know, is it going to be enough time?
Yeah. So,
and is that enough time?
It will be enough time if you're dedicated. So if you go through the books, not just use driving time or breaks at work to listen to the books, like I did for 5 months. So I didn't have any dedicated time. When I did AKT, for example, I had every day 2-3 hours, and in the end, after the kids went to sleep, I sat down and read the curriculum. So if you have dedicated, 2 months is enough. But for me, what it was useful is to read all the books, because it looks at the same problem, the same big syndromes in geriatrics, delirium and so on. But it looks from different angles, and it's quite useful, because you can then understand a lot more. And the other thing is, if you don't just want to read, there is a lot of podcasts, like NDT podcasts. There's lots of podcasts if you look on.
I think I saw some as well. Yeah.
Yeah, and they're quite useful, actually. They're very useful. On the geriatric medicine journals, there are free webinars, for example, specifically on nutrition is the last one, and they're free to watch. So, yeah, you can learn in different ways, but if you're dedicated, if you have at least 2-3 hours every day, or, it depends how you learn as well. I think it's very valuable. I'm a very small learner, so I don't read. I don't,
You like to you're more of a listening kind of. You like to listen to the
Yeah, looking,
words.
but also trying
Yeah.
to make the structures and pictures and yeah. So yeah, when I do side effects, I always make faces with all sorts of things anyway. So I'm
Wow.
trying to make a pictogram of side effects to
Yeah.
remember that way. But if you're dedicated, it is enough so much.
Yeah. And
Basically.
Richard asked his Oxford Handbook enough, but it sounds as if you've said that read all the books, any books that you have on the resource list as well that's on the website, and
Yeah.
that should be enough to cover the different styles and the things they want you to learn. But yeah, I haven't
The
actually
written
thought
test,
about having read it.
it
Need to look through it.
depends on your sort of clinical expertise. If you're quite experienced and exposed to acute medicine, you probably don't have to go to the cases. But
Mm,
in the cases, they're very clever, sorted. So just looking at how they fix those cases, it will give you an idea of the depth and the understanding you need to have
mm,
for hyponatremia, for example,
mm.
or any acute problems. So
Yeah.
it depends what kind of background do you have.
Mm. Yeah, no, I think I definitely am seriously considering it because it only comes around once a year, and if I miss it, I'll have another year to wait and think about it. Maybe March is a good time. And then the practical, what's the time difference between the written and the practical exam?
My case, there wasn't much time. I started
Oh, right.
the written, I think it was end of June or beginning of July, and then I the practical was straight after in August. So I had like
Oh, right.
4 or 5 weeks in.
So in terms
But
of normal time would be,
I've already been through the books, so
yeah,
it
okay.
wasn't scary in that respect. Basically,
Yeah,
it's scary not to know how to prepare because there is no information whatsoever on the
I know. This is why
website.
this is
And
so useful.
yeah, I know that's what I wanted to tell you because they just said be yourselves basically, and yeah, you'll pass. I'm sure the pass rate is 93%. So
Wow.
basically, unless you hurt the patient, as I said, or do something silly, you're going to be fine.
Yeah,
So I wouldn't worry at all for the practical exam. The written exam is quite tough though, so there's a lot of information, and it's exactly how it is in real life. When you do a
mm,
geriatric ward round, you're bombarded with information from all over the place, and you have to focus and make a decision that is important to the case, sort of thing. I'm making it sound very important, but there is a lot of information on the questions. You need to filter to get to
yeah.
the right answer.
No, I think AKT is good practice actually.
For the exam, if you're not strong on how to manage unwell patients, read the cases because it would be very useful.
Mm. Thank you so much, Maria. Anyone else have any other
Well,
questions before we go? I mean, this live has been recorded. So we'll record it. So if you want to watch it back, you're more than welcome to. If you've missed any information or joined a little bit later. Uh, but I think that is pretty much what I wanted to know. And I think I will do it, and I probably will mither you again or something. But
fine. I mean, you can contact me on Instagram if you have any questions. If anybody has any
yeah,
questions, it will be on recording. And I will try to answer to the best of my knowledge. I'm sorry for
yeah.
the technical hiccup.
No, no, it's been really useful. I definitely feel a bit more confident. Sometimes you need to see someone to have done the diploma, like done something for you to feel like, yeah, I can do it. Because there's no information about, there's a lot of information about what's expected, but not for the practical. I think for the written there was a lot, but not for the practical. So it's good to know kind of
In
what
a
to
way,
expect, the stations, and that's really useful.
it's all in there in the sense they do.
I think we've lost signal. Oh, thank you for everyone's questions though. Yeah, hopefully next A to Z series will be in January. We haven't decided on a topic yet, so but I think she's back. Hi. No, it's been so useful, Maria. Honestly, it really has. I think people can, because there was a lot of like kind of, oh, what is it like? Who's done it? I know you know a few people who've done it, but you're the only person that I know who's done it. So it's very useful to know exactly what to expect, and maybe hopefully I'll be more prepared. Um, but I'll keep people updated on my progress through that. Damn the internet! It's probably Virgin Media. We've been having issues as well. But thanks to everyone who's joined, and hopefully see you next time. Thank you. I just want to say bye to her properly, because if she goes, then I'll just ring her later. But at least say bye on the live properly. Oh, she's gone. Thank you so much, everybody. See you on the next live. I'll just end it.